Right, let's start then. Welcome to INRI Park's first international online networking event, and this is the fourth session in the series of sessions we're running this week. Just a few practical bits of information before we start the talk. So this session is being recorded, but mainly the welcome and the talk, not the question and answer session afterwards. We will have a poll because we would like to know a little bit about you, and I will tell you about a Padlet we're using this during this event and how to be involved. Then we'll have the talk and then the question and answer session. So the whole point of this week is to raise awareness, but also to discuss what is psychosocial adjustment and rehabilitation. So obviously it's something to do with how people learn to live with a long-term condition, but that's not enough. We need some more detail on that. We need a much better understanding. We need to define these topics. So to that end, we have made a Padlet tool available online with 6 questions where you could link on and give your thoughts, your ideas, your answers to these questions. If you look at page 8 in your delegate pack, there's a link so you can find the Padlet tool and have a look at it. And please, there are no right or wrong answers. Just let us know what you think. On Thursday, we will then have a facilitated session where we will go through these questions and hopefully have a discussion with anybody who joins the session on Thursday. So it would be really, really great if you have time to join that session on Thursday. So finally, ways of being involved. You might already be a member of INRI Park in the LinkedIn, through the LinkedIn group. If not, please find the group on LinkedIn and request membership, and everybody's welcome as a member. If you want to be a little bit more actively involved, you can become a member of the Lived Experience group. This is led by Steph Killich, or actually she's in the process of establishing that for the moment, so we could really use some Lived Experience members. You might want to be a member of the leadership board, or maybe you have some ideas for research collaborations or anything else. Please feel free to contact myself. The email addresses are at the bottom of this slide, or you can contact us through the LinkedIn group. So before we move on, I'll just first of all end this slideshow. And share screen. There we go. And then I will just ask you a few little questions. So I'd really, really appreciate if you could answer these questions. So what you consider yourself to be in this context, it's just a single choice reply. So if you have more options, just take the one that's most relevant today, and then also where you are from regionally. So it looks like we have. It looks like we have most of the responses. So just sharing the results. And again, like in an earlier session, this is really good. We have both people with living with a long-term condition. We have a researcher, we have rehabilitation professionals. So that's really great. Everybody's from Europe. That's probably to do with the timing of the session. So right, thank you for that. I would like now to ask you, Kate, to share your screen and begin your talk. Unfortunately, Kate's camera doesn't work, so you'll just have to make do with her slides and her voice. But Kate is going to present to you how they apply behavioral science in long-term conditions, and her colleague Jess Walburn will also present at some point. I think, Kate, you have your whole PowerPoint page now. You need to change to the presentation view. There we are. Excellent.
Yeah.
And yeah, and I will stop my video and my microphone. So take it away, Kate. We're looking forward to it.
Thank you. Me too. And thank you very much for inviting us and for coming along to the talk today. I'm just seeing how I move these slides on. Can you see that? Move on to the next slide if I do that.
Yeah, can see.
You can. Cool. Okay. So I'm Kate. I'm a health psychologist, and I'm going to be co-presenting today with my colleague Jess, who is also a health psychologist. We're going to be talking about applying behavioural science methods and frameworks to develop patient support programs for people living with long-term conditions. So I'm just going to start by discussing the role of patient support programs, or PSPs, in supporting people with long-term conditions. Then I'll go on to demonstrate how we use behavioural science models and theories to develop PSPs that are both patient-centred and evidence-based. And then we have two project examples. So I'm going to present on a project example with patients with multiple sclerosis. And then Jess will talk about a condition called xeroderma pigmentosum, or XP. So I'll hand over to Jess at that point. Okay, so what I'm seeing on my screen is not the presenter mode. Are you seeing the full screen when you look at this?
Yeah, I can see the full screen, Kate.
You can see the full screen, great. Okay, so PSPs are structured programs that are designed to provide the information and support people with long-term conditions need to manage their disease and their treatments over the long term. They're often funded by manufacturers of disease-modifying therapies. So these are long-term treatments for chronic conditions. And they're sometimes focused on supporting patients on a particular treatment, or they may be focused on supporting all patients with a particular diagnosis on any treatment. And they can provide information and support via a range of channels, which may include mailed or emailed information and medication reminders. Also nurse support and counselling, which may be face-to-face or via the telephone, and also websites, mobile apps, and patient hotlines are other options. A systematic review in 2016 identified 64 published evaluations of PSPs, covering a wide range of conditions and also a wide range of geographical regions. So these are being rolled out all over the world. And findings supported positive impacts on treatment adherence, on patient-reported outcomes such as quality of life and functional status, and also healthcare utilisation and costs. So development of PSPs involves input from different groups of professionals, combining methods from both service and experience design and behavioural science. And what you can see on the right there is a patient experience map, and this is developed as part of the service and experience design process. So this process...
Sorry to interrupt you. The slides aren't moving on for me.
Okay.
It's for other
Sorry,
people.
there's something strange going on.
I can just see the first screen, the first slide.
Okay. I think there's something strange with the screen sharing. So,
Kate, do you have the black screen? If you go to the black PowerPoint screen, you can control your slides from there.
is that moving now?
Yes.
Yes, moving now, yeah.
Okay. Sorry. So did anyone see anything other than this screen?
Not while you were talking, no.
Okay.
Yeah.
Okay. So this is the screen that I was just talking through. So can you see this on full screen now?
Yeah.
Yeah. Great. Okay. So you can see on the right-hand side there an example of a patient support program delivered via a mobile app. And often we develop these through a mobile app, but also nurses as well. So the patients can use their mobile app to contact a nurse if they need support. So on this one, you can see the patient experience map that's developed as part of the service and experience design process. So this involves breaking down the patient experience into a series of steps or touch points. So we look at what happens for the person with the long-term condition from the moment they develop that condition all the way through the process. So they would often go for a series of tests, may receive a diagnosis, may receive a misdiagnosis, may go on to different treatments, and then we'd map that out across long-term management as well. And the purpose of doing that is to identify pain points or problems in the patient experience, and to be able to develop some solutions around this so that we can improve patient experience. Behavioural scientists are part of this process, and what we do is we conduct literature reviews to identify behavioural determinants, and these are modifiable factors that influence patient or clinician behaviour across the journey. We map these to behavioural science models and frameworks, identify the active ingredients for an effective patient support programme, and create behavioural content, such as patient articles, nurse training, and we develop evaluation frameworks as well. So this slide presents an overview of that process. So we start by analysing lots of evidence, research evidence, interviews of patients and service users and stakeholders. We use this to design the elements of the patient support programme, then develop it, implement it, and evaluate it. So in terms of behavioural science models and frameworks, we quite often use a model called the COM-B, which you may be familiar with. And this is a very widely used model in the behavioural science literature, which classifies research insights into three main types of factors. And these factors interact to shape behaviour. So the first is capability factors. So that's the individual's physical and psychological capacity to engage in the behaviour. The second is opportunity factors. So those are factors that lie outside the individual that prompt the behaviour or make it possible, such as access to care and social influences. And then motivation factors, and this relates to all brain processes that energise and direct behaviour, such as emotions, beliefs, and perceptions. We can also use a model called the theoretical domains framework, which identifies 14 domains that are linked to these three components. And these domains are the mechanisms of action by which interventions lead to a change in behaviour. So as you can see on the right-hand side there, you could change capability via knowledge or via skills. You could change motivation by addressing beliefs or emotions, for example. We often also use an approach called intervention mapping, which allows us to select theory-based intervention methods that match the identified behavioural determinants. So once we know what we want to target, we can refer to a series of tables that list out approaches that are evidence-based and allow us to address these processes. Okay, so the first case study we'd like to talk about today involved developing and implementing a patient support programme for NHS patients with relapsing remitting MS, starting a new self-injectable treatment. So the aim of this programme was to support patients to be able to self-inject at home, but also to be able to manage their MS more widely. So a brief bit of background about MS. MS is a lifelong condition that affects the central nervous system. It's nearly 3 times more common in women than men. Most people are diagnosed in their 20s and 30s. The symptoms are variable, and they may include muscle stiffness, spasms, fatigue, and pain. Also problems with balance, coordination, bowel and bladder control, or sexual function, as well as cognitive difficulties and emotional difficulties. Relapsing remitting MS that we're focusing on here is the most common form of MS, and it involves periods of flare-up, but also periods of good or complete recovery. So people's symptoms can be very variable. Over time, many people with RRMS will develop SPMS or secondary progressive MS, and this is associated with disability that increases over time with few or no relapses. Treatment of MS requires a multidisciplinary approach, including disease-modifying therapies, symptomatic treatments, psychological support, and rehabilitation interventions. And patients are typically started on first-line injectable or oral drugs, and then switch to higher efficacy second-line treatments, which may include infusions over time. So for this project, we started by mapping out the patient journey and thinking about the tasks that are involved for the patient. And you can see that here. So at pre-diagnosis, patients need to recognize early symptoms. They need to feel confident to seek help and be able to navigate the healthcare system. When they're diagnosed with MS, they need to be able to make sense of the diagnosis, to understand what this means for them, and to adjust to becoming a patient. When they start on treatment, they need to be able to balance the treatment benefits and drawbacks and start to develop self-management routines that work for them. When their treatment is switched, they need to recalibrate their expectations, manage the emotional implications of change, and start to develop new self-management routines around this treatment. And then over the long term, patients need to be able to maintain motivation to self-manage. They also need to be able to adapt to change in their disease and their wider life circumstances, and to be able to draw on support as needed. We then mapped out the pain points. So these are key challenges across the journey for patients, and they're informed by a review of the research literature. So you can see at pre-diagnosis, a key challenge is diagnostic delay and uncertainty. At diagnosis, many patients have difficulties adjusting. At treatment initiation, patients often experience difficulties managing the disease and treatment. At the point of treatment switch, this can be quite emotionally difficult because of the fear about transitioning to SPMS, and also uncertainty about how effective this new treatment will be. And then over the long term, there's substantial disease and treatment burden, and MS can substantially interfere with daily activities and have negative consequences across all aspects of life. So we aim to develop a program that would help to improve these challenges for patients. The next step was to look at the behavioural determinants and the intervention methods at each point. So at each stage of the journey, we thought about what are the capability factors, so what kind of knowledge and skills do patients need to be able to carry out these tasks? What are the motivational factors and the kind of beliefs, expectations and emotions that will influence their experience? And what are the opportunity factors to do with the wider environment and social processes? So we mapped all of those out. We also used intervention mapping to identify intervention methods that would be relevant across the journey. And you can see those in the table. The PSP was designed to provide support from treatment initiation onwards. So from the moment patients start on this self-injectable treatment at home, we're aiming to build their knowledge, their capability, motivation, and opportunity. Okay, so through that process, we then designed the actual patient support program. You can see a table on the right that shows the main elements and how these relate to the behavioural dimensions and the intervention methods. And this is something that's just about to be launched in the next couple of weeks. It'll be available free for patients through the National Health Service in the UK. Patients will have a choice of support channels, so they can either access the programme through their nurse or through an app or a combination of both. We've trained the nurses in evidence-based interventions to support the patients, including techniques from motivational interviewing, CBT and ACT. We've embedded a screener to assess individual areas of need and to tailor the support to the individual, and that's repeated at key points in the journey. We've built in scheduled nurse calls, so particularly when patients are doing their injections at home, they get a call from the nurse and they use some of the techniques we've trained them in to build their confidence and to find out what other support needs they have. The digital content through the app is designed to match what the patients receive through the nurse if they choose the app. They receive a tailored action plan so that they can navigate content in the app that's relevant to their specific areas of concern. They also have self-injection reminders and trackers to help them keep track of their treatments and also to record any experiences they want to discuss with their nurse. We've developed articles on different aspects of managing the disease and treatment, such as managing MS at work, activity pacing, goal setting, managing negative emotions. And those are all available through the nurse or through the app. We've built in interactive content, such as knowledge check quizzes and techniques from motivational interviewing, CBT and ACT. And we've also built in data collection for ongoing monitoring and evaluation. Okay, so that's a very quick whistle-stop tour, but I'm going to hand over to Jess now to talk about the second case study.
Thanks very much, Kate. So the second case study is just really to highlight, I suppose, the breadth of experience, working within the commercial sector. And I'm taking you through a programme that was developed for NHS patients with a condition called xeroderma pigmentosum. And next slide, please. And just to highlight, this was funded by the NIHR under its programme for applied research scheme. And just to highlight that this was an initiative and a programme developed at King's College London and not at IQVIA. Briefly, xeroderma pigmentosum, or XP, is an extremely rare skin condition. There are only 100 patients in the UK. And what happens in XP is that the body can't repair UV damage to the skin. Next slide, please. And this means that people with XP are at significantly higher risk of skin cancer, both non-melanoma and malignant melanoma. And there are other sort of more cosmetic changes to the skin as well as a signal of UV damage. The current treatment at the moment is to monitor the skin, and this is done by the clinical team, who then remove any suspect growths or changes. Moving on, please. But the main task really for patients is to prevent UV damage. And they do this by a range of behaviours, such as wearing UVR protective clothing, checking UVR levels, sometimes wearing a visor, and generally trying to reduce their overall exposure. And you can see some photos there of the different types of protective activity. What we do know is that adherence to this is patchy. It's a difficult thing to do on a regular daily basis. We use intervention mapping to develop an intervention to support patients, and you can see a summary here of the key barriers if you like, and this is the logic model for the poor photo protection. So it's centered around doubts about the need to protect in different environmental conditions. It included barriers such as lack of social support, worries about the negative responses of others to photo protection, and a prioritization of living normally, in inverted commas, which overrode the prioritization of photo protection. And this was also combined with a lack of confidence to protect in the presence of barriers, but also a lack of habits and routines and self-regulation for the behaviour. Next slide, please. So as I said, we based the intervention approach on intervention mapping, the design that came out of that. And just to say, we did observational research for the first part of the grant to identify those barriers that were in the logic model. And the actual final design was focused around 7 one-to-one sessions with the facilitator using a range of different techniques adapted from acceptance and commitment therapy, CBT, and motivational interviewing. Initially, the sessions were weekly and then reducing in frequency. It was a personalised program, so we would ask patients to complete a screening questionnaire to identify which of those barriers was more relevant to them. And then the content for each was tailored to those particular barriers. So we developed materials that the facilitator would use to work with the patient. Next slide, please. So as I said, there were a range of different materials that we developed, and we've got a magazine there which was developed. There was one magazine developed, and each article within the magazine would include behavioural change techniques, and the facilitators would guide patients to particular articles that were relevant for them. We designed and produced a sunscreen application video, both to show how to apply sunscreen correctly, but also how to embed it within the routine of daily life. We developed text messages that were personalised, so these were designed to address the barriers in the logic model, but each person would only get barriers and messages that were relevant to them. Next slide, please. We evaluated the intervention using a randomized control trial that was specifically designed for very small populations, because in the end we had 16 patients who entered the trial, and we increased numbers, in inverted commas if you like, by having a delayed control arm. So in the first part of the trial, the control patients were randomized both to receiving the intervention or being the control, and the control group then received the intervention the following year. We measured the amount of UV radiation reaching the face by a complex method, combination of a UVR monitor as well as diaries that the patients completed. We did a quantitative process evaluation and also a qualitative process evaluation, and the results should be out later this year. Next slide, please. And then just to highlight, I suppose, a different aspect of the work that we do at IQVIA, we also develop and disseminate best practice across industry. So supporting industry to develop patient support in a robust manner, making sure that we use health psychology frameworks, and ensuring that the designs can be evaluated in a robust manner. Next slide, please. And just to summarize here that in our view, health psychologists play an important role generally in improving care and support for people with long-term conditions, and that there are many ways that one can do this in terms of developing interventions that are directly available for patients, as well as training healthcare professionals. Working with industry allows the opportunity for the interventions to be developed and delivered to patients free of charge, and also funded over the longer term. So, a challenge within university sector is that the programs are often developed for a limited period, then tested, and then it's kind of more challenging as to how the support is funded beyond the trial. In the XP program, I'm working with the clinical team to embed the program within routine clinical care, but that is a challenging aspect. And yeah, we as a team work to ensure that the interventions are centered around the needs of patients and caregivers, grounded in evidence, and ensure that we have robust ways of measuring the impact right from the start. And so and a key aspect is the refinement of programs over time. So we ensure that the evaluation allows us as a team to benefit from the experience of the running and at a practical level of patient support programs, to allow them to be refined and improved over time. So it's not a static program. Next slide, please. And just to highlight that we are an expanding team. We've got a range of experience within the team. I'm not going to read out our biographies, but you can see there we have a range of experience across different sectors. And we use that working as a team to ensure that the programs we develop are informed by the best of our knowledge and skills. Thank you. That's the last slide.
Well, thank you very much. Before we take any questions, I will just stop the recording.